Hello, guys. My name is Dr. Tesfaye Telila. I'm one of the interventional cardiologists here in Atlanta, Georgia, with Piedmont Heart Institute. Today, as part of the Ethiopia-American Doctors Group lecture series on cardiovascular medicine, I'll be talking to you on introductory talk on structural heart disease. The objectives of this talk will be to introduce the expanding scope of structural heart disease, to briefly review the common structural procedures, to review common valve lesions, particularly mitral stenosis and aortic stenosis, and to briefly outline available percutaneous therapies. I don't have any financial disclosures, and I will not be discussing detailed specific structural interventional procedures. However, if need be, we will be discussing those procedures in subsequent lectures. Structural heart disease interventions represent a wide range of percutaneous treatments covering a wide range of congenital and acquired diseases of the heart and valves that were previously treated surgically or simply not treated. As you can see in the definition of this segment of cardiovascular medicine, it does not include coronary artery disease and intervention like percutaneous interventions. If you step back and see the branches of cardiovascular medicine, you can divide it into electrical abnormalities, coronary abnormalities, and structural abnormalities. And the fourth and big part of cardiovascular medicine is also vascular medicine. Any of these could be congenital or acquired abnormalities. Therefore, today we'll be just talking about this segment of cardiovascular medicine that is relatively new and a kind of high yield for you guys, as you see a lot of valvular heart disease patients back home. The spectrum of the structural heart disease spans not just valvular heart disease, but also some congenital defects in the heart, like atrial septal defects, patent foramen ovale, also closure of left atrial appendage in patients who have AFib and cannot undergo systemic anticoagulation, also closure of ventricular septal defect, paravalvular regurgitation or paravalvular leak, a closure of PDA and management of hypertrophic cardiomyopathy, closure of left atrial aneurysm, and also other structural interventions are all categorized under this multidisciplinary segment of cardiovascular medicine called structural heart disease. So the key fact about cardiovascular medicine, as you guys probably know, cardiovascular disease is the _1 cause of death globally, and about 17.9 million cardiovascular deaths in the world reported just in the year 2016. And unfortunately, 31% of all global deaths are due to cardiovascular disease. And over 3/4 of this mortality is actually happening in the low and middle income countries. And the two major cardiovascular killers are stroke and heart attack. And the stroke prevention and cardiovascular interventions, they do have crossroads that they meet. Two major cardiovascular pathologies or problems that are strongly associated with stroke are presence of atrial fibrillation and also presence of patent foramen ovale in some group of patients. As you know, atrial fibrillation is a very common cardiovascular problem that affects a lot of people, particularly non-valvular atrial fibrillation in this country, and valvular atrial fibrillation is usually the driver in your setting. And what happens with atrial fibrillation, as you probably know, is the development of blood clot in the left atrial appendage. And what we usually do for those patients is actually to initiate blood thinners or anticoagulation therapy to protect them from from future stroke development. However, some patients, by their very nature, are at a higher bleeding risk, and they might have had GI bleed or intracranial hemorrhage in the past, and they're not good candidates for systemic anticoagulation. In that case, we tend to place this device called the watchman device to close the left atrial appendage and protect them from clot formation in that pocket to protect them from future stroke. This is a patient of mine, 70-year-old female who has a history of atrial fibrillation on systemic anticoagulation. And essentially, she subsequently developed GI bleed and presented to the emergency room with severe anemia. Because of the presence of right coronary artery stenosis that would potentially require intervention down the road, we did not want her to get a stent and at the same time go on a therapy for her atrial fibrillation with triple therapy, which would require aspirin, Plavix, as well as oral anticoagulation, which will intensify her risk of developing future GI bleeds. Therefore, we decided to place this watchman device. A 30mm device was implanted easily in her left atrial appendage, and she essentially went on to live a normal life. A patent foramen ovale is the second crossroads between stroke and structural heart disease. And as you can see here, the PFO or patent foramen ovale is basically a communication between the right atrium and the left atrium. And if patients have deep vein thrombosis and in a blood clot, can actually paradoxically traverse this patent foramen ovale and they can develop a stroke. And in the absence, as you know, patent foramen ovale is very common and even in the normal population, about 25%. Therefore, we have to exclude other causes of the stroke before we attributed this stroke as a PFO-associated stroke. If it is PFO-associated stroke, we can close this hole with one of these two devices that are approved for PFO, the Gore device or the implanted device. This is a patient of mine, 37-year-old female who had a CVA or stroke, was proven by MRI and negative event monitor with 30 days monitoring with no evidence of atrial fibrillation. She did not have any other alternative etiology for her stroke. Therefore, we performed a 2D echo, which showed presence of patent foramen ovale with right to left shunting, and her rope score was suggestive of PFO being the cause for her stroke. Therefore, we decided to close her PFO with a 25mm ASO device. And this is a fairly simple, straightforward procedure. That's a transvenous access, 8 to 12 French sheaths, depending on the device size. And essentially deploy the left atrial disc first, and then the right atrial disc. And subsequently, patient goes home the next day. The vast majority of structural interventions, however, is valvular intervention. And the bread and butter of the structural intervention, even in the US, is severe aortic stenosis and transcatheter valve therapy. The second most common is mitral valve therapy. And of course, pulmonic valve is also the other valve that is usually treated by pediatric structural interventions. 3 of the 4 valves, as you know, have FDA-approved transcatheter therapy, some sort of therapy, but the tricuspid valve is the only valve that does not have any FDA-approved device at this point in the United States. The tricuspid valve, hence called the forgotten valve, and although new evidence is building currently, suggesting that tricuspid regurgitation is actually is actually associated with increased mortality. So a bunch of devices are currently in development. If you look at valvular heart disease and the structural interventions, the incidence of rheumatic valve disease is on the decline globally. However, this kind of precipitous decline has not been shown yet in the developing world. We don't see rheumatic heart disease that often in this country. It's very rare. However, as you know, I did my medical school in Ethiopia, so I do know that rheumatic heart disease is actually very, very common. On the other hand, degenerative valve disease is actually on the rise in the Western world, which is mostly due to calcific degeneration of the valve. Whenever you talk about general management of valvular heart disease, you can approach it in 4 different phases or stages, essentially. The most important and the cheapest way to prevent is to prevent. And prevention, when I say prevention, particularly in the context of rheumatic heart disease, is essentially to perform primordial prevention, which is hygiene and avoiding overcrowding, and essentially to minimize the risk of developing streptococcal pharyngitis. Also, in terms of calcific degeneration of valves, you can talk about controlling hypertension, hyperlipidemia, also radiation. All those things can cause valvulopathy. Detection of the valve, on the other hand, is really the second most important strategy to minimize the risk of developing or progressive or end-stage valve disease. For example, if you're just waiting for the patient to present to the emergency room for mitral stenosis, they usually present to the emergency room late in the course of the disease, which is very, very troubling, because at that point they might have had already end organ damage, they might have had pulmonary hypertension, have had right-sided heart failure called pulmonale, and it's really that maybe too late in that regard to really fix their valve pathology. The third is surveillance. If you detect the valve disease, not every valvular pathology would require intervention at the same time that it was detected. So you do need to do some sort of surveillance in terms of doing serial echoes every 1 to 2 years, and clinical follow-up in a valve clinic. Those are really, really important steps. And the fourth and the last one, obviously, is where we spend most of the healthcare dollars, is to intervene on those patients who are symptomatic and they also have concomitant severe valvopathy. Believe it or not, most of, I shouldn't say most, but about 50% of patients who have severe aortic stenosis, they go undetected even in the Western world. And therefore, early detection is really, really, really key, particularly for patients who have rheumatic mitral stenosis. If they have the lesion and if they're not symptomatic, and if you actually give them antibiotics like penicillin, you may actually delay their recurrence. And if they don't have recurrence, and the fact is they develop severe mitral stenosis because of the recurrence of acute rheumatic fever. So you might really prolong the time to the time when they need intervention. So once you diagnose any valve disease, meticulous follow-up is really, really key. In terms of surgery, not every institution has a surgical backup. And if they don't have surgery, the patient should be referred to a center that is capable of doing those surgeries, or a center that is capable of doing balloon valvuloplasty. There is general variability of access to surgery in even industrialized countries. However, that is mostly because of the concept of surgical turn down, which means that the patient does have valvular problem, but they cannot really undergo the surgery because they also have multiple comorbidities that will put them at a very high risk to survive the surgical procedure itself. You know, if you look at valve disease, and I want you to look at it as a progressive disease. Okay, there's the valve disease that you're at risk. Okay, which is stage A to stage D, which is severe symptomatic valve disease. When you say you're at stage A valve disease, that means you just have a risk. You may be hypertensive, you may have bicuspid aortic valve, you might have had acute rheumatic fever, but you don't have a valve pathology yet. So that person needs to be paid attention to. Their blood pressure must be controlled. You know, and they should get antibiotics for acute rheumatic fever and managed accordingly. Stage B is progressive disease. Patient does have some kind of valvopathy. You know, they do have mitral regurgitation, mitral stenosis, but they're not severe yet. And stage C is they're severe, and if they're C1, they did not have any cardiomyopathy. But if they're C2, they did. Excuse me. They did have some kind of cardiomyopathy. That is stage C2. Stage D is where we intervene most of the valve pathologies. If you have severe aortic stenosis, and if you have symptoms, which means you're symptomatic severe aortic stenosis, the mitral stenosis, the same thing, then you do need something done to that valve. It's a mechanical problem, it has to be fixed mechanically. So let's take a look at the mitral valve. You know, the mitral valve is one of the two AV valves that sits between the left atrium and the left ventricle. It's also one of the most intricate and I would say complicated valves or the four valves in the heart. It has multiple connections, and a pathology in any of these two connections can actually result in mitral regurgitation. This fibrous structure that anchors the entire valvular apparatus is called the annulus. It is the saddle-shaped structure, which is kind of not on the same plane, and actually the leaflets are attached to the annulus, the anterior leaflet and the posterior leaflet, and the closure lines of the leaflet is called commissures. Okay, the closure line when the anterior and posterior leaflets touch is called commissures. That is what you need to pay attention to when you evaluate a patient with rheumatic mitral stenosis, because that is where the valvulopathy happens, and commissural effusion is actually a pathognomonic sign for rheumatic mitral stenosis. And at the tip of the leaflet, as you can see, there are these string-like structures that are connecting the tip of the leaflet to the papillary muscle. They're called chordae tendineae, and the chordal insertion to this structure is called papillary muscle, is where the mitral valve apparatus actually is. If you think about it, you can have mitral regurgitation either from the ventricular pathology, which is called secondary or functional mitral regurgitation, or you can have mitral regurgitation from pathologies affecting the valve structure itself. That's called primary mitral regurgitation. The pathophysiology of mitral valve stenosis, particularly mitral stenosis to secondary to rheumatic, is essentially valvulitis. Okay, post-rectal pharyngitis can give you antibodies. Those antibodies essentially through a process called molecular mimicry, confuse cells from non-cells and destroy the tips of the mitral valve apparatus. And when that essentially heals, it causes fibrosis. Acutely, they may have mitral regurgitation, but going forward, subsequently, they will develop mitral stenosis. In terms of mitral regurgitation, it could be primary valvular pathology, which is myxomatous mitral valve prolapse or fibroelastic disease. It could be chordal rupture secondary to acute myocardial infarction. So it could be ventricular problem like SAT secondary mitral regurgitation. And the etiology of all this could be congenital or acquired. And the diagnosis of mitral pathologies could be regurgitant or stenotic. It's usually by clinical evaluation as well as echocardiography. This is just a 2D echo showing the parasternal long axis, and this is the mitral valve, anterior leaflet of the mitral valve, posterior leaflet of the mitral valve. This is the aortic valve. It's just kind of to give you an idea of what it looks like with echocardiography. Anterior septal wall, infralateral wall. It's kind of the apex. You don't see that wall. So talking about mitral stenosis, we already talked about the etiology of mitral stenosis, and the most common cause of mitral stenosis in the world is acute rheumatic fever. Okay, the second most common, and particularly in the Western world, is calcific degeneration of the mitral valve. The mitral annular calcification can happen, but most of the time that gives you mitral regurgitation, not stenosis, but it can give you stenosis. When you talk about rheumatic heart disease for the purpose of this talk, I talk more about rheumatic heart disease because I think that's probably what will help you the most, because that is what you will be seeing the most back home. And it affects children and young adults living in the developing world, which is about 80% of the world's population is considered developing at this point. And at least 15.6 million people are affected by rheumatic heart disease. And so it is a disease of public health importance. And it obviously and unfortunately disproportionately impacts children and young adults living in low-income countries. We see rheumatic heart disease very, very rarely in this country. And that is mostly due to population dynamics and migration, and so sometimes refugee crisis. Otherwise, essentially, rheumatic heart disease is very rare here. And like I said, it is a disease of public health importance compared to HIV, tuberculosis, and malaria. Rheumatic heart disease or acute rheumatic fever, it is fairly underfunded compared to the impact that it actually causes in the world. This is to show you what happens with acute rheumatic fever. Patients will develop a post-streptococcal pharyngitis, and then they will have valvulitis, and acutely they develop mitral regurgitation. Like you can see here, this color Doppler showing you a posteriorly directed severe mitral regurgitation jet. And also you can see this the anterior mitral valve leaflet is prolapsing. Okay, this could be directly from the infection. It could be annular dilation. Also, posterior directed jet is indicative of the presence of a lesion on the anterior mitral valve leaflet. This is a postmortem pathology just to show you how endocarditis or valvulitis can actually show, on gross anatomy, and those patients can have concomitant myocarditis, which could actually be the cause of their demise if they were to die during this acute phase of acute rheumatic fever. This is a more familiar type of echocardiography that you guys have seen in the past. It shows you chronic mitral regurgitation and mitral stenosis concomitant. And the way you tell it is chronic is that if you look at the left atrial size, it's big, and left atrial dilation. there is the volume and pressure overload, there is a posteriorly directed jet. If you see the mitral valve apparatus, it's very restricted. It doesn't even in diastole, it's supposed to be open, it doesn't open freely. And as you can see here with my cursor here, the anterior mitral valve leaflet is restricted and it's not moving. That sign is called the hockey stick deformity of the anterior mitral valve leaflet, which is very pathognomonic for severe mitral stenosis of rheumatic origin. If you think about what happens as a hemodynamic consequence for mitral stenosis, it's fairly simple. What happens is there's mitral stenosis, there will be pressure and volume overload in the left atrium. The left ventricle is fairly preserved, really nothing happens to the left ventricle. The left atrium will be dilated, there will be left atrial hypertension, there will be pulmonary venous hypertension, and there will be secondary change in the pulmonary vasculature, and patient may have pulmonary hypertension that with secondary changes that is permanent. And that pressure obviously will transduce to the pulmonary arteries, and the RV will be dilated, big and baggy, and that will cause congestive hepatopathy, systemic anasarca, and also, sometimes these kids, they can have gut edema, protein losing enteropathy, and they may actually die of malnutrition. Therefore, as you can see, before patients develop permanent damage to their systemic organs, we need to do something about this lesion. It's a mechanical problem. It needs to be opened up. If it's not intervened either surgically or with percutaneous route, patients will develop this, green consequences that we cannot really salvage them from that late in the course of the disease. I can't emphasize this anymore. Echocardiography is really the cornerstone of diagnosis of mitral stenosis or any valve lesion for that matter. I do realize that we do a lot of very meticulous physical examination in Ethiopia, which is all perfect, and I'm very proud of that. However, just the mere presence of mitral stenosis will not really dictate what we do for these patients. So we have to perform echocardiography. You guys pick up all the, the opening snap and the diastolic rumble, and you can tell it's severe, but you can't tell me if there's leaflet calcification, commissura calcium or subvalvular apparatus. Therefore, for me to decide which patients actually would benefit from balloon mitral valvuloplasty versus surgery, you have to do echocardiography. Preferably TEE at some point if you're planning to intervene, but for monitoring and diagnostic purposes, do 2D echocardiography, surface echo suffice. There are different ways to assess severity of mitral stenosis, and we will talk about those when we talk about the echo session. Either myself or Dr. Mikias will discuss those diagnostic and techniques. But I would say one thing, pressure gradient across the mitral valve is heavily dependent on heart rate. Therefore, if there is one variable that you have to really depend on to assess the severity of mitral stenosis is valve area. So the management of mitral stenosis, just like anything in medicine, it starts with medical therapy. Okay, you have to stabilize the patient. If they have pulmonary edema, they have to be diuresed, and they have to have optimal beta blocker therapy on board, because tachycardia is essentially the enemy of this patient. As you can imagine, the problem with mitral stenosis is diastology. They cannot fill the ventricle because the valve is too tight to open in diastole. Therefore, if for some reason this patient gets tachycardic, if they have fast heart rate, they don't have the diastolic time will be compromised. Therefore, they will not have time to fill the ventricle. Therefore, they will develop flash pulmonary edema. Therefore, it's very, very important that we slow them down, give them some diastolic time for them to fill the ventricle. However, like I said, mitral stenosis is a mechanical problem, and the therapy is going to be mechanical therapy. It's already fibrosed. We're not going to reverse the severe mitral stenosis with diuretics or any other medical therapy. And in terms of intervention, it could be percutaneous therapy, or it could be surgical therapy. The other complications of mitral stenosis that you need to be aware of is presence of atrial fibrillation. Because the left atrium is dilated, because there is left atrial myopathy, patients with mitral stenosis, they are at an increased risk of developing atrial fibrillation. And the kind of the double-edged sword in this patient is that if you have atrial fibrillation, the risk of forming left atrial appendage thrombus and even left atrial thrombus is very high as compared to those patients who have non-valvular atrial fibrillation. Now you have AFib and RVR, you have a diastolic problem that you can't feel and the ventricle runs really fast. That is going to be a disaster. Therefore, you have to make sure their heart rate is controlled, and they have to be on systemic anticoagulation regardless of their CHA2-VASc score. You know, the CHA2-VASc score is the score that we use to stratify patients to see if they need systemic anticoagulation or not for those patients who have non-valvular atrial fibrillation. Do not apply that scoring system for mitral stenosis patients, please. And the only anticoagulant that is currently tested or approved and known to work in patients with valvular atrial fibrillation is actually Coumadin or warfarin. And pregnancy, as you know, with mitral stenosis is a really, really bad combination. So we recommend that patients, try not to get pregnant when they have severe mitral stenosis. If they have severe symptomatic mitral stenosis during pregnancy, it's probably worthwhile to give them balloon mitral valvuloplasty prior to the delivery to help them during that second stage of labor. So in terms of interventions, we can do balloon mitral valvuloplasty, which is a very mature procedure, or we can do surgical intervention. They're both class 1 indications, but of course, which one to choose depends on the favorability of the valve for this therapy. Surgery is done for patients who have unfavorable anatomy. That means their valve is very calcified. They have at least moderate to severe mitral regurgitation concomitant with the mitral stenosis. They also have other valvular pathologies. They have mitral concomitant tricuspid regurgitation or aortic regurgitation or even aortic stenosis. So those patients seem to be doing better with surgery and usually get mechanical valve. They have AFib, so the point is, you give a mechanical valve that would last them for the rest of their life, than giving them a tissue valve that will degenerate in about 10 to 15 years, and they need another surgery. Of course, this needs to be handled on a case-by-case basis. Some patients with rheumatic mitral stenosis, they would like to get pregnant, and in that case, we have to really tailor a therapy to their needs. The problem with mitral stenosis, rheumatic mitral stenosis, is commissural fusion. So the therapy has to be directed to commissurotomy, opening up the commissures that are already fused. And this can be done by a surgical or percutaneous approach. And of course, I'm here to talk about percutaneous interventions. So I'll tell you how we do this procedure. There are two systems. There is a percutaneous balloon system called the NOA balloon, and there is also a metallic system that I have never used. In this country, we don't use it, but the balloon system is introduced to the market back in 1984 by Dr. Inouye, and it was done actually in 1982, but it wasn't published until 1984. So before we take the patient for a procedure for balloon mitral valvuloplasty, they have to be, evaluated with 2D echocardiography and assessed for favorability. So the appropriate patient selection is really, really key for a successful outcome. And what we do with that is we essentially assess their echo score or the Wilkins score for mobility, thickening, calcification, and subvalvular thickening, and we score the valve essentially from 4 to 16, and the lower the number is the better. All this mobility, thickening, calcification, and subvalvular thickening will get a score of 1 to 4, and any score that is greater than 8 will predict that the patient may not be a good candidate for balloon mitral valvuloplasty. So those patients typically undergo surgical replacement. However, if they have favorable anatomy, they will be a candidate for percutaneous balloon mitral valvulotomy. Like I said, this was initially introduced in 1984 by Dr. Inouye. To my knowledge, Dr. Inouye was recently actually in Ethiopia. He's from Japan. So it is my understanding that this procedure is done in some parts of Ethiopia, and it's a very successful and mature procedure. The catheter that is used is transvenous catheter, and it's a transeptal procedure. And the balloon catheter is made of polyvinyl chloride. The balloon itself is a very slick balloon. It has 2 latex layers of nylon and polyester micromesh in between the 2 layers. And the balloon is very interesting, and it has a very variable elasticity in a way that actually when you inflate the balloon at the mitral position, on the distal tip inflates first, and you can actually pull it back a little bit and it will anchor on the mitral valve. And then when you continue inflating, the proximal part will inflate, and lastly, the middle part, which actually performs the commissurotomy, will inflate last. And the balloon comes in 4 different sizes, 24, 26, 28, and 30 millimeter balloons. And selection is based on height in centimeters divided by 10 plus 10. That will give you kind of the ballpark of the size of the balloon that you need to use. Intraoperative details, obviously, like I said, it's a transfemoral access, transfemoral vein access, transeptal puncture, and imaging guidance is usually with TEE or fluoroscopy. Some institutions have reported that they use intracardiac echocardiography. However, obviously, in my experience, we use transesophageal echocardiography for most of our procedures. This is just to demonstrate how the distal balloon inflates first, the proximal balloon inflates second, and then the middle part inflates third, and that is what performs the commissurotomy. Expect results of successful balloon mitral valvuloplasty, immediate 10 to 25% improvement in pulmonary hypertension. But this is, with caveats that the reversal in pulmonary hypertension is only if we catch the disease early in its course. If the disease has already advanced pulmonary hypertension, you may not be enjoying this great results. Pulmonary artery pressure also declines over weeks to months, and severe pH usually does not resolve completely. Atrial fibrillation resolution has been reported in few patients, but persistent symptoms despite successful balloon mitral valvuloplasty may suggest severe diastolic dysfunction. This is a 3D TEE just to show you what a successful balloon mitral valvuloplasty looks like. And if you look at the third row here, you can see that the commissures, which is the closure line of the valve, is actually cracked. So that is called commissurotomy. But what is you do here in the green arrow, that is actually the valve leaflet was also lacerated. So that is not intentional, and you don't want to do that. So a little tear that the patient did fine, but if this is really a major tear in the leaflet of the valve, that may cause severe mitral regurgitation, and that won't be a good outcome. So what are the contraindications? Not every patient can get balloon mitral valvuloplasty. Some patients have left atrial clot, left atrial appendage, or the free wall. This is a patient that I took care of when I was a fellow in the University of Wisconsin in Madison. She was a 57-year-old Hispanic female who came in with pulmonary edema and subsequently found to have severe mitral stenosis. We, in interventional cardiology, was requested to see her for consideration of balloon mitral valvuloplasty, but at the same time, when we did follow-up echocardiography, we detected this large left atrial clot. So therefore, she underwent surgical valve replacement and clot removal, and also left atrial appendage ligation and the Mays procedure for her atrial fibrillation. If the patient has more than mild mitral regurgitation, they're also not a good candidate for balloon valvuloplasty, and they severe concomitant aortic valve disease also, like I said, will be a contraindication or relative contraindication at least to balloon mitral valvuloplasty. So in a nutshell here, treatment and prevention of rheumatic fever and rheumatic heart disease would be key in the management of patients with rheumatic mitral stenosis. Really, the key here is rheumatic heart disease is actually a very preventable heart pathology, really a one valve disease that can be impacted upon by really primordial prevention by early detection of hygiene-related problems and the spread of the streptococcus pharyngitis. You can minimize the risk of developing group A streptococcus infection, which is called primordial prevention. But once patients or kids develop a group A streptococcus infection, primary prevention is going to be key because we have to treat that streptococcus infection as quickly as we can and as early as possible. And once patients, if that is not caught there, and patients may have acute rheumatic fever, and now that will be secondary prevention, but it's still very, very important that we have to make sure patients are well treated for them not to develop valvulopathies. Okay, rheumatic heart disease may finally develop if we miss all these 3 stages of prevention. Of course, then the patients do have mitral stenosis or mitral regurgitation. In that case, we do what is called tertiary prevention. Really not a prevention, it's just where we spend most of the healthcare dollars, is where we try to optimize therapy for these patients who already have valve disease. And that could be valve surgery, that could be anticoagulation, that could be management of their heart failure. They may have stroke and now they're disabled, they may be in rehab, all those things. And of course, mortality is going to be inevitable at that point. Therefore, what I'm trying to show you here is that, if we intervene early in this group of patients with high risk of rheumatic heart disease, we can make a dent in the pathophysiology of the disease and also prevalence of this lethal disease. This is the end of my lecture series for part 1. In part 2, you will be talking about aortic valve pathologies And if you have any questions, please feel free to contact me, and I'll be happy to answer your questions. And thank you for your patience and your attention.